Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. And today, I really have the pleasure of talking to somebody that I've admired his work because Dr. Richard Price has been doing work with his son, which is something that I have two sons, and I think the work you're doing is terrific. So Dr. Price is the lead author, along with his son, Max Price, of the winning poster from last year's Congress, the Young Investigator Poster Competition, and it was entitled Improved Mood and Weight Gain Mitigation Following Switch from Aripiprazole to Cariprazine. Richard, how are you?
Doing great. Thanks for having us.
Oh.
Sorry Max couldn't be here. He's on his pediatrics rotation in medical school.
Oh, my.
He's actually the lead author, so correction on that.
Yes, that's terrific. He's actually in medical school. This is something else, and he's already published now with you. Let's talk about this particular study. Now, this is not all comers, right? These are patients with bipolar disorder, is that right?
These are bipolar 1 disorder patients who fell into the depressed phase while taking oral aripiprazole.
Got it. And so they are stabilized, if you will, or maintained on aripiprazole. Is that correct?
Correct. That is correct.
And this is a real study. I mean, you got IRB approval, I noticed, right? And you had a protocol
yes.
and everything.
Yes.
Mm-hmm. Terrific. All right. Well, tell us a little bit more about, let's just back up and say, what was the motivation? What was the rationale behind this?
Well, at the time, insurance companies were giving some difficulty approving some of the newer branded medications.
Yeah.
Perhaps in their mind, they see the class of the partial dopamine agonist, which includes aripiprazole and cariprazine, as being similar enough that one should have to fail aripiprazole trial first, adequate dose and duration, before they would even consider cariprazine, thinking that they're similar enough without major distinctions. So that kind of defied our clinical experience, and we wanted to conduct a study that would put some data behind it and to illustrate that there perhaps were some unique benefits of cariprazine over aripiprazole.
Yeah, that's a very interesting point you're making, that insurance companies tend to say, okay, these are all D2 partial agonists. I like to call them the ABC drugs, aripiprazole, brexpiprazole, cariprazine. And yet they're very different in many ways. I mean, first of all, they don't all have the same ratio of agonism to antagonism at the D2 receptor, so they're not the same there. And then, of course, the other receptors that they bind to are very different. They have different fingerprints or profiles. And so it sounds like your clinical experience has been that they feel different or they can work differently.
Yeah, we were seeing patients falling into the depressed phase on aripiprazole. And we wanted to avoid the common practice of psychiatry of polypharmacy, just adding on additional agents, antipsychotic, anti-manic, antidepressant agents, anxiolytics. And we thought maybe just a clean switch at equivalent doses that we worked out could alleviate some side effects and help them with their mood.
Yeah, Richard, I've said for a while now, all antipsychotics are antipsychotic, but they're not all antidepressants. And so it sounds like your experience mirrors mine, that some of them have a little more antidepressant effects than others. That may include cariprazine over aripiprazole. And the other thing is, Richard, insurance companies seem to like to practice medicine without a license, which sounds like part of your frustration here. They dictate what we do here, which is frustrating. Well, tell us.
There are also some psychiatrists who don't believe there's really nothing new under the sun.
Yeah.
So they believe that everything is just a Me Too or a little tweak, for patentability or profitability. And, we discern that there's a clinical benefit. We want to make that known so people can up their game and help their patients.
Boy, I really appreciate that. This is obviously a wise clinician who's carefully observing his patients. And I really appreciate what you're saying. As you know, I've been doing clinical trials for the past 30 years to help get these new medicines approved. And I always say, why would a company spend all the money it takes to develop a drug and get it to the market if they didn't feel there was some differences, maybe advantages to the medicine? So I think I, again, applaud you for what you're doing. Tell us a little more about the design here and who these patients were and how you measured success, if you will. What were you looking at?
Sure. Well, another thing we wanted to fill a gap in is often when medications are approved, they're compared to placebo. So a lot of things are better than placebo, but are they better than the standard of care that we're doing now?
Yeah.
And that's another question we wanted to answer. So these were 37 patients taken from an outpatient practice, a mix of male and female, a mix of ethnic diversity, but they had all had in common bipolar 1 disorder in the depressed phase on varying doses of aripiprazole, which had been stabilized in maintenance, and who had also had some weight gain over the years. The aripiprazole, which is not well known. People think of aripiprazole as weight neutral, but if you look at the original studies and also some clinical experience, people can gain substantial weight and have difficulty losing it despite mitigation efforts like melatonin, topiramate, naltrexone, or metformin. So again, minimizing polypharmacy, maybe a clean switch could do something for them.
Yeah, I completely agree with you. It's not well appreciated, I think, and certain patients seem to be more vulnerable than others. And aripiprazole, we'll talk about the mechanisms in a minute, maybe. We'll talk about the receptor profiles in just a minute. So you were looking at now these were patients who were starting to have breakthrough depression, is that it? Yeah.
Right. So they had been stabilized on aripiprazole, and then they fell into the depressed phase. And that's not entirely surprising, because although aripiprazole has a maintenance indication, it really only showed efficacy in preventing manic and mixed. It doesn't show efficacy in either treating acute depression or preventing depressive relapse. So that was information from prior studies we were aware of, but then we were seeing that. And I think most people's knee-jerk reaction would be, well, keep the medication, as its stabilizer.
Right.
And then add on some additional agent to address the depression. But we try to avoid that because of adherence issues and also because of the additive effects of side effects. You have more agents, you have more side effects, you have adherence issues. So we thought maybe a clean switch could be appropriate.
Yeah. There also are pharmacokinetic drug-drug interactions. For instance, aripiprazole is metabolized by CYP3A4 and 2D6. And so if you add, say, fluoxetine or paroxetine, they're inhibiting 2D6. And maybe some people don't appreciate that. So I, again, applaud you. I'm a big fan of either as few meds as possible or at least rational polypharmacy as much as possible. But so that's interesting. Now, so what were you using as your outcome measure for efficacy? How did you judge efficacy?
Right. So we looked at the Clinical Global Impression Bipolar Severity of Illness Scale, just because it's user-friendly. We're not doing an official clinical trial here. We're not heavily working up these patients. We want something that's quick and easy. So it's a 1 to 7 point Likert scale, 1 being normal and 7 being like the most extremely ill. So the patients were assessed on their last visit of being on aripiprazole, and then they were assessed again, blinded rater, on their last assessment on Cariprazine when we closed the books on tallying the data. We had those 2 data points.
Got it. What was the duration of treatment with Cariprazine before you measured that?
So Cariprazine was up to 127 weeks. With a mean of 37 weeks. Okay. And the aripiprazole was much longer because it's been out longer. It was up to 728 weeks, 728 weeks with a mean number of 95 weeks on aripiprazole.
Got it. So, I mean, this is really watching the patient over a longer period of time. This is not like a 6-week study, for instance, or something like that. Now, what other things were you monitoring? What other things were you measuring?
We were also looking at their weight. So we took their weight at the beginning of when they started aripiprazole, what they were on their last dose of aripiprazole, and then what they were on their last assessment, close of study on Cariprazine, and we're able to capture those numbers as well.
Were any other medications varied, added, subtracted? You sort of kept them the same as much as possible, or how did that work?
Yeah. So the aripiprazole was in a maintenance dose going into this, so we weren't moving that dose around. But the Cariprazine was, we worked out a protocol of how we would switch them. So if they were on anywhere from 2 milligrams to 10 aripiprazole, they got 1.5 Cariprazine, clean switch, partial agonist. Yeah. And if they were on above 10 milligrams aripiprazole, they got 3 milligrams Cariprazine. But from there, they were allowed to titrate dose depending on response and side effects. So the range ended up being 1.5 to 4.5 of Cariprazine, and the range on the Aripiprazole with a mean of 2 milligrams, so toward the lower dose. And the Aripiprazole was anywhere from 2 to 30 with a mean of 11 milligrams. Yeah. So about 10 milligrams to about 2 milligrams, 1.5 Cariprazine doses.
Makes sense. You know what a lot of people don't appreciate too, Richard? Everybody knows, I think, about Cariprazine having a very long half-life. And then one of the unique warnings it has in the label, of course, is late occurring adverse reactions. But I don't think people appreciate Aripiprazole also has a pretty long half-life. So, sometimes you have to take that into account, when you're switching, because the Aripiprazole is going to hang around for a little while, and that's fine. But I'm sure it was generally well tolerated, I'm assuming, the switch?
The switch was very well tolerated. That was one of our 4 major findings. Because people ask all the time, how do you switch agents? And when it comes to switching partial agonists, we find that a clean switch is well tolerated. So that was one of our 4 main take-homes, was the switch was well tolerated.
Okay. Well, let's go over those 4 findings. Let's start maybe with the efficacy. What did you see when you did this?
Well, we found that their overall mood was improved. And in terms of numbers, they were rating at about a 5 on the severity of illness scale, which put them at markedly ill.
Right.
Intrusive symptoms distinctly impair social and occupational function, cause intrusive levels of distress.
Yes.
And they came down to about a 2.8, which is about a 3, which puts them at mildly ill.
Yeah.
And while symptoms are minimal, if any distress or difficulty in social occupational functioning, but noticeably improved subjectively as they would describe it.
Yeah. That's a very important finding, and I'll tell you why I think that's important. A 3, meaning mild. The difference between a 3 and a 4, to me, is the most important difference, because a 3 says maybe you have symptoms, but no, not functional impairment. As soon as they're functionally impaired, it has to be a 4 at least. So to me, getting them under 4 is a very, very clinically important outcome, Richard. So that really is an important finding, I would argue. And then, let's see, what were the other 3? So you mentioned it was well tolerated.
The direct switch was well tolerated. Yeah. Their mood improved. Yeah. And the other 2 findings were the reduced weight gain and the stability in maintenance going forward in terms of keeping them out of depression. Because since we had enough data to follow them out of some long period of time, they did well in maintenance. Yeah. And I think that was an important new finding at the time because there hadn't been any maintenance studies ever conducted at that point.
That's exactly right. That's a very important distinction because, as you mentioned, aripiprazole is approved for maintenance. And I did those studies, Richard. They were actually pretty not so well designed, not the way we would do them now. These were patients who were acutely manic, responded to aripiprazole, and then maintained. So it's sort of like cherry-picking people who had responded, and the most recent index episode was mania or mixed, but not a depressive episode, as you mentioned. And at this point, cariprazine is not FDA approved for maintenance treatment of bipolar, but of course, this is a chronic illness. We don't just treat somebody for 6 weeks and then stop an effective medicine, right?
Right. So in our experience, it's worked very nicely in maintenance because we follow these people beyond, the traditional time period. Like in the maintenance study that recently came out, it was about 39 weeks post-randomization. If you follow them much longer, you'll see that it holds up. And in that study, only 20% relapse, which is a very good rate. And you don't see antihistaminergic effects, anticholinergic effects, such that when you stop the medication, you fall off a cliff.
Right.
It has nice long half-life, many metabolites, CAR, DCAR, DDCAR, so that patients times are on an intermittent regimen and they're still holding up. So even long that they've stopped it, it looks like, well, they didn't relapse compared to placebo. They're not on placebo. They're still hanging on to some small nanograms of metabolites where the receptors are, and they continue to do well. So as a maintenance treatment, we find that this works quite nicely. And I think you have to have a study that goes much longer to start to see a separation, particularly in depression.
Yeah, that's really interesting because you're right. I mean, I think it's hard for people to take a pill every single day the rest of their life. So I think sometimes people miss doses, for whatever reason. And so that is a nice property here, that the blood level won't nosedive. And so now you mentioned you mentioned the weight mitigation. Can you tell me more details about that? What did you see with the weight change?
Right. So when they had finished up with their Aripiprazole, they had gained, got up to 90 kilograms, plus or minus 21.5 kilograms. After switching to the Cariprazine, their weight had been mitigated down to 83.9 kilograms, plus or minus 19.2. Yeah. So they either were not continuing to go up and up, it had plateaued, or some people, lost a bit of weight, which was appreciated. But more than that, they not just were physically lighter, they were like mentally lighter. And they cognitively sharp and feeling less flat, less blah, less blocked. And we talk about anhedonia, more able to kind of feel their feelings and their emotions. And in bipolar, that's so important because people are very concerned that if they're going to be on mood-saving medication, they still want to enjoy like life, like maybe not mania, but still like have some taste of pleasure and joy in life without feeling completely blocked. Of course. And there was very much a subjective difference embedded in those functioning clinical global impression findings that they were just more alert, awake, alive, and physically lighter. Having, had less appetite and perhaps some cardiometabolic improvements as well, which we didn't measure. But, when the weight comes down, the labs tend to improve.
Yeah, we know that's a good thing. Yeah, that certainly mirrors my clinical experience with this molecule as well, Richard. I have to agree. And let's talk a little bit about mechanistically what might be going on, realizing that, the old disclaimer, we don't know exactly how these things work. We know what they do in test tubes and animal models, but I think this does translate clinically. Let's first talk about the efficacy. How could we explain better antidepressant efficacy, let's say?
Well, if you look at the D3 receptor, so you have like a 10-fold difference. You have 0.085 nanomolar, and lower numbers are better compared to just 0.8 nanomolar on aripiprazole. So it's like a 10-fold greater affinity compared to aripiprazole. That comes across clinically, like cognitive sharpness, focusing, a brighter affect. Again, the anhedonia being resolved, libido. So that's that piece. And then in terms of the 5-HT2C receptor, where many of our penes act and can cause some of that massive weight gain and appetite, it has a lower affinity there too, 134 nanomolar compared to 15 nanomolar. So it's also almost a 10-fold difference in affinity there. So that those may have something to do with what we're seeing clinically, but it's always just so exciting to be able to tie the chemistry and the neurobiology to something that you're seeing in practice. And you could see that in the studies, but like until you really do, not even head to head, but crossover, these are the same patients. It's not like they're matched.
Exactly.
These are the very same people in this group who move to this group. And although it's open label for them, we switch people all the time. If people aren't satisfied, they'll tell you. They're not going to say, well, this medicine's better because they were hoping to get better. They'll say, this medicine is not as good. I want to go back to what I took before. And nobody did want to go back. They're very satisfied.
Yeah, it's almost as if every patient was their own control in this study, right? Now, getting back to the receptors, which is really interesting, you mentioned 5-HT2C, and I don't know that a lot of people think about H1, histamine blockade, and you mentioned something very important, that cariprazine has a triple-digit affinity. I think you said 137, somewhere around there. Aripiprazole has a double-digit, around 15. It turns out double-digit affinity is probably clinically relevant. Especially some people are more sensitive than others. And also what a lot of people don't appreciate is aripiprazole does have also a moderate affinity for H1, whereas cariprazine has very little. And certainly those two together, we think, this is one of the reasons, for instance, olanzapine and clozapine have so much weight gain. They both have significant affinity for both of those receptors. So that certainly makes sense what you're saying. Now, from the efficacy point of view, I completely agree that antagonism of D3 appears to increase dopamine release into certain parts of the brain, prefrontal cortex, for instance, probably limbic system. And this, of course, can improve cognition, as you said. It can improve mood. It can improve hedonic tone or the motivation reward system. Now, some people say, well, wait a minute, if you're increasing dopamine, aren't you going to make them manic? Well, remember, you've got the D2 blockade. You've got the ceiling on there to keep that from happening. So you're really kind of stabilizing the dopamine is how I think about it.
Well, the other way I think about it is the partial agonism, meaning that you have the lower doses for depression and then you have the higher doses for the manic. So when you do a maintenance study, you have to be able to titrate the dose in. You can't lock them into a dose.
Absolutely.
And we didn't do that. Although those were our switch doses, as I mentioned, we allowed ourselves to be able to go up and down to account for, how they were feeling. Some depressed episodes are more mixed features and you go a little higher. And some are more like anergic, low energy, low motivation. You need to go a little bit lower. So it's a dynamic medication that can cover really the full spectrum, depending on how you can dial that in. Again, makes for a very nice agent for acute, but also in maintenance.
It's interesting you said that you find sometimes a little higher for those with mixed features. That's exactly what our friend Steven Stahl found. He did a sub-analysis of the pivotal trials of cariprazine for bipolar depression, and he found that those who seemed to need the 3 milligram versus 1.5 were those with more mixed features. So that's fascinating that your experience really mirrors what the clinical trials showed. And Steve Stahl was the lead author on that poster with Roger McIntyre. Another thing that we should talk about, very few people are talking about another receptor, Richard, and that is the 5-HT2B receptor, serotonin 2B, not 2A. And turns out cariprazine has as high affinity for 2B as it does for D2. It's actually the second highest affinity below D3. And we didn't used to know a lot about that receptor, but recently we found that receptor, if you block it, it disinhibits serotonin release. So it's probably an antidepressant mechanism in addition to the D3. And that could also explain this differential efficacy you're seeing for depressive symptoms. So I find that also fascinating. But then that's the point. These drugs are different, aren't they? They all have different fingerprints. Yes, they are both called D2 partial agonists, but beyond that, they differ.
Yeah, and it's not a matter of the numbers. I think you can see it in the patient experience. And I've spoken to many colleagues who really maybe are not big fans of trying new things. They're set in their old ways.
You're being very tactful. I appreciate that.
Try it out. Your patient's struggling. Say, well, they already failed Abilify. They're not going to respond to cariprazine. Try it out. Let me know. I'm very interested in hearing how they did. And it's very surprising. It's a find. A lot of people are still out there on Abilify struggling. It's a very popular medication. It's still widely used. And it's a clean switch. It's low-hanging fruit. And you can make a substantial difference in their lives just with a clean switch like that.
I mean, aripiprazole historically was a very important medicine. And of course, it was really terrific. But, we refined things and we have improvements, if you will. And we know that some people do better with one than the other. And so I think that's why this study is so helpful. I think it's very clinically relevant. It helps guides clinicians in this decision-making and gives them the confidence, I would say, to try this new thing. How about other side effects besides weight? Did you notice anything else as far as maybe gastrointestinal side effects or anything else, sedation, anything?
Sedation, not. So there can be late occurring effects with cariprazine as its metabolites build up over several weeks. So some people might get a late onset insomnia. And they may not understand where it's coming from. And the clinician may be concerned, are they getting manic? Not necessarily getting manic, whereas you need to increase the dose. It's just that the metabolites have kicked in. So sometimes we'll lower the dose back down just to be able to mitigate that effect rather than raise the dose thinking that you're getting mania. It's a side effect. The other thing which comes up frequently is manageable is akathisia. So akathisia, the restlessness sensation can also be mitigated through adjusting the dose. Whether it's intermittent dosing or it's just bringing the dose down or titrating more slowly. Sometimes antidotes are helpful, like a little propranolol to help mitigate that. But it's not necessarily a reason why you have to stop the medication because it's such a useful medication. To deal with some akathisia with an antidote is not really a heavy medication. Many people find propranolol calming for their anxiety anyway, so it's really not been a limiting factor. We just saw that in a very few number of people,
Right.
because we allowed ourselves to flexible
Right.
dose titrate.
Well, aripiprazole is not free of akathisia either.
Right.
And so I'm assuming you didn't see a whole lot of new akathisia, maybe some I could see during the switchover. Hey, Richard, have you ever
Because I
tried
think they'd already been,
what's that?
Yeah, I think they were already sensitized, because they were switching. So it wasn't
Yeah.
like they were really new to this the molecule. So we didn't really see as much as someone who maybe was de novo.
And of course, there's some overlap there. As I said, the aripiprazole comes down slowly. So you are, sort of adding it on top, and gradually that's going to come down too. Hey, Richard, have you ever tried mirtazapine for akathisia? It can also help with sleep. Obviously, there's weight issue there.
Right. This was a population that was obviously very sensitive to their weight.
Good point.
They'd already been, as many bipolar depressed people are, struggle with metabolic syndrome. Bipolar is correlated with that.
Yeah.
So for people who are depressed, we don't want them to gain even more weight when they've gained weight from the depressed agents.
Yeah.
So although it's a very effective strategy, particularly for people who can't eat, can't sleep, we don't necessarily go to that first.
Yeah. The other one that I've heard people use is gabapentin. I don't know if you've ever used that, which apparently can help akathisia, anxiety, maybe a little sleep, certainly pain, Have you ever thrown that into the mix?
Yeah, we sometimes throw that in. More commonly, a little bit of hydroxyzine also helps with the anxiety and some akathisia as well. Yeah. And people can use that for sleep, and it doesn't seem to cause the weight gain. It might even help a little bit. What's
nice about hydroxyzine, and our friend Jonathan Meyer taught me this, it actually has very little anticholinergic effect. Almost all the antihistamines that we use are burdened with anticholinergic. They go together, but this one doesn't have as much. And certainly anticholinergic effects are to be avoided like the plague, if you ask me.
Sure.
Yeah.
Yeah.
Yeah. Well, great. Well, this sounds terrific. Now, what does, we've talked a little bit about the clinical implications, but what would you say to those clinicians who are listening in? And as we said, maybe some of them are a little timid. What do you think are the clinical implications here? What would you recommend to our colleagues?
Okay. Well, first of all, if you have patients currently on aripiprazole, and I'm sure you do, for either bipolar spectrum or adjunctive to major depressive disorder, these are on-label uses for cariprazine as well. And it's a clean switch to make. Again, the protocol we use was low doses 2 to 10, go to 1.5, above 10, go to 3, check in with your patient, titrate accordingly. And if you like, track some data, see how their mood rating scales are doing, see how their weight is doing, if that's their issue. Even if they don't have the mood issue, the weight issue, it's just for the mood effects. Yeah. I think you might be pleasantly surprised what you're getting from that. Yeah. And then you may not have to add additional agents. Yeah. And the patients will thank you when they come in, maybe in just 2 weeks, even just 2 weeks. You'll see their affect is different, and they'll report to you how they feel. Yeah. So that's a very rewarding thing that I'm not sure everybody's aware of, but that's a big take-home point of this.
Yeah, I forgot to mention, cariprazine is actually one of only a handful of medicines that has demonstrated efficacy on anhedonia, which you were talking about before, and I think it is so critically important. Anhedonia is associated with functional impairment, with suicide, worse outcomes, and so on. And there are very few. But Roger McIntyre published the anhedonia subscale of the MADRS they pulled out from the pivotal trials, and it moved the needle, so to speak. So I really applaud you for using that. I think more of our colleagues need to really dig a little deeper into anhedonia. I don't know that we're as skilled at looking at that one as we are at mood, for instance. Another question.
Yeah, it's also been associated with treatment resistance. Yeah. So when you're giving people, let's say, SSRIs or SNRIs, and of course you're helping their anxiety and their comorbid OCD and a little bit of their mood, you also could be flattening, as you're diminishing dopamine levels with increased serotonin. Yeah. And, you're trying one SSRI after the next and an SNRI. And sometimes you add in, something that's a dopaminergic agent, such as cariprazine, very potently so, the D3. You might get that breakthrough that you were looking for, even in your MDD patients, which we didn't look at here, but certainly in the bipolar depressed patients as well.
Yeah, well said. I think cariprazine has demonstrated a strong antidepressant signal, whether it's unipolar or bipolar depression. And there's really only a handful. Really, the only other one FDA approved for both unipolar MDD and bipolar is our old friend quetiapine, which is burdened, of course, with weight gain, very effective medicine. So this is a nice option, alternative. Speaking of which, how, just in general, Richard, I'm curious, how do you see way more patients than I do. How do you manage insomnia with a medicine like this? Are there any particular recommendations or particular medications you found effective?
Yeah, so Seroquel would be one of them.
Mm-hmm.
But again, if you're getting the weight gain off of Seroquel, you might not want to use that one.
Yeah.
Some people do very well, again, back to the hydroxyzine.
Mm-hmm.
The hydroxyzine could help anxiety, akathisia, and sleep. Maybe a higher dose at night for sleep and a lower dose by day if necessary, PRN for that. Some people will go to trazodone because it's a commonly used medication in the low doses, not so much for depression, but just for sleep. But there are many strategies, even over-the-counter melatonin, over-the-counter sleep aids, of course, sleep hygiene. We can't forget about non-pharmacological strategies as well. And sometimes just lowering the Cariprazine dose.
Yeah, interesting.
Once those metabolites have built up, the dose might need to be lowered.
Yeah. How about Zolpidem? Is that reasonable?
Yeah, well, that's good for falling asleep, but there's a tolerance people build to it, meaning after about 3 days on it, people find that it might not be working, but if they want to take it for intermittent use, that seems to work. Just for falling asleep doesn't necessarily get them at night.
Do you have much experience with the DORAs, the dual orexogen drugs? Yeah.
Yes, I do. Yeah. So the Quvivic and the Dayvigo and the Belsomra. So the way I differentiate them is by their half-lives. So Quvivic has the 8-hour half-life, which coincides with the, most people's target night of sleep. Belsomra is a bit longer, 12 hours, and then the Dayvigo could be even 18 hours. So I think if you're looking for more of that, 8-hour night sleep, the Quvivic might be helpful. Yeah. They don't necessarily work right away, so you might need to give a little bit of time, might be more for chronic insomnia, but they seem to be pretty effective. And there's an interesting signal in the Alzheimer's population about perhaps clearing out the cobwebs, the plaques and tangles, which is another very interesting finding. So I think we're learning a lot about this.
Yeah. We have some drugs in development that are orexin drugs for, J&J has one, Celtorexant, for depression. They're using it as augmentation. So, that's another system, another biologic system, neurotransmitter system that, stay tuned, we'll learn more about. Richard, you've now had some experience seeing patients for relatively longer periods of time on these two medicines. And besides the short-term brightening, clearing of the head, if you will, which I've certainly seen, what are you seeing longer term here?
So longer term, you have to be prepared to adjust the dose. I mean, this is a medication that's approved for bipolar 1 mania, mixed depressive states, and unipolar depression as an adjunct. So you have to be prepared to adjust the dose as life throws its curveballs at you. I mean, bipolar is not a static condition, and life is not a static condition.
Right.
Sometimes there's stressors in life that bring you down, and sometimes there's excitements in life that pull you up. And sometimes there's, major stress that makes you agitated and puts you into a mixed state.
Yep.
And you have to keep in mind that bipolar is a moving target. Yep. And Cariprazine is a dynamic medication for a dynamic condition. So you may start off at 1.5, but let's say a person, it's a summertime, getting a little bit manicky, you have to be ready to adjust that sleep. You have to adjust that dose. And let's say it's the winter time, feeling a little bit more blue, maybe you back off on the dose. And as long as you're ready to kind of dial that dose in as the patients need it and don't just get complacent and say, this is your dose and that's where you stay, you could really use this medication quite effectively over the years.
Yeah, I love that. I've said for years, don't set it and forget it is my way. Dosing does need to be dynamic and flexible and meet the patient's needs. I think that's terrific. We were talking a minute ago, too, about sleep hygiene and lifestyle interventions, which are so important. And I think sometimes what happens, too, is when patients are depressed, it's harder for them to do the healthy lifestyle things, and that includes exercise. But as they get feeling better, I find I can talk with them more, and they can do more of these lifestyle interventions. And one of the things I wanted to mention, of course, exercise is very evidence-based. I mean, exercise has demonstrated antidepressant and anti-anxiety effects. We know there's a host of health benefits. It's anti-inflammatory and so on. So how do you handle prescribing, let's say, exercise? How do you handle that in conjunction?
Well, I try to be a role model. I tell them that I exercise every day, whether it shows or not. I follow my wife's fitness HIIT regimen. It doesn't have to be a lot of hours. It could be something maybe 30 minutes, but where you rotate between some weights and stretching and cardio. And it could be just something you build into your life. But you're right. It's hard to do it when you're depressed, bipolar depressed. And that's why a lot of people, when they're bipolar depressed, they have that atypical depression where they're overeating and they're oversleeping. Sleeping. And then although you have medications approved for bipolar depression, if they're sedating, that's probably not where they are right now. They need to be more activated. So giving them Cariprazine in the morning, getting them activated could be helpful, getting them on a good sleep schedule, recruiting some family members, if they're around, friends, to kind of keep them in the game. So the behavior activation is probably the first step because cognitively, they may not be there yet. They might be too negativistic, too, even potentially pathologically guilty about how they feel, and they can't even really think their way out of it or talk their way out of it. But you can just get them on a regimen, healthy eating, healthy exercise, 30 minutes a day. And then once that mood starts to improve through the medication, through the exercise, now you can do some meaningful talk therapy because they're here, they're with us, their insight is back.
Yeah, I certainly agree with everything you're saying. That is absolutely true. Also, it's been shown that they can be more adherent to other medication regimens, such as medical medicines for medical conditions and things like that. There's another thing I wanted to circle back around to, and we kind of skipped over this, Richard, but you mentioned kind of the reason you chose this efficacy measure you used, the CGI-BP. And I wanted to circle back and say that's really fascinating because it is extremely well validated. It's used in virtually every rigorous bipolar study, and yet I find it to be very clinically useful, which is what you're saying. And I find it really mirrors clinical practice because in essence, like you said, you're seeing how sick is the patient. I think we make these global determinations every time we see a patient. Oh boy, they're pretty sick, and you just assign one number from 1 to 7. So tell me a little bit more about using that scale.
Yeah, I mean, I've been involved with some clinical trials and I feel like there's many scales that are used. Some of them are redundant. The patient gets fatigued. They're not necessarily paying attention. They're not, filling it out accurate anymore. Like in a busy practice where you could see a patient every 10 minutes, there's not that much time to, embed research. But research is critical because it helps guide our practice. So if you want to be able to keep up your practice and help a lot of people, but at the same time, take a step back and look at your work and look at what we're doing here and pick up on trends that are important and take the time to write it up and to publish it and then go through the revision process. It's a lot of work. It is. But it could make a great impact beyond just your community and your patients because people read these studies and it could help people you've never met. So we need tools that are quick and user-friendly for both the patients and the practitioners.
Yeah, and who knows, you might actually win a prize if you present a poster at a meeting, It could happen.
It could happen.
Yeah. But I echo your point. I'm not one of those KOLs who beats people over the head and says you have to do rating scales. I recognize they're time intensive. They require some training, and as you said, and so on. But this is certainly one that's, I think, very practical, easy to use. And as I said, mirrors what we do clinically. Finally, what other recommendations for future research do you have here? I know you're always doing something. You're always thinking of new things to do. You mentioned you and your son are on to another project here, but before we talk about that, tell me a little more about maybe what other kinds of studies vis-a-vis Cariprazine or relative to other medications for bipolar. What else do we need to know here?
So this is the question I'm most excited to answer. Because I'm a creative person, I'm a musician, and I like to think outside the box, and I want to do whatever I can do to help patients with the tools that we currently have. And if we don't do these studies, which is hard to convince funders to do studies if they don't necessarily even know that there's a signal there. Here are the following areas where I feel there is a signal and is worthy of study, and someone hopefully out there in the ether, whether it be pharma or practitioners or academia, will take up the charge. So number one is negative symptoms in schizophrenia.
Oh, I love it.
I have seen miraculous things with cariprazine and negative symptoms. And I'm aware there's one like FDA level study that was done. And I wish at some point a second study will be done, because I don't think that we have great treatments that are well tolerated, for negative symptoms. But this is a huge need within psychiatry.
Could not
we
agree
have
with
many
you more.
agents that help positive symptoms.
That's right.
That can knock them down and make you neurolepticize.
Right.
But the negative symptoms are so debilitating. But when you see someone shake your hand, look in your eyes, smile appropriately, like, whoa. So again, that D3 and the partial agonism was uniquely suited to this, where you can block when you need to block for the positive symptoms, but you can stimulate where you need to stimulate for the negative symptoms. This should be, in my opinion, with another study, the first FDA-approved treatment for negative symptom schizophrenia.
Well,
and many agents have tried and failed.
I was actually involved in this, Richard. The study you're talking about is published by George Nemeth. It was done in Europe. It's historic in many ways, but one of them is it's one of the few studies we have where one drug clearly beat another. It was statistically significantly better than risperidone for negative symptoms. And when the company went to the FDA, they said, oh, that's all European data. You're going to need to generate some data in the U.S. And so, yes, I completely agree with you. I do hope that they go ahead and do another study, because that would be very clinically relevant. So it's interesting you've noticed that clinically too. It's
when you see it, it's incredible. Next, and I know this is in development, is ASD.
Oh, yes.
Because right now, for the spectrum, we're giving the kids and the adults risperidone and Abilify.
Yes.
Again, we have the metabolic issues. We have gynecomastia, sometimes permanent. So having an agent like cariprazine with a better cardiometabolic profile, that in my experience has worked very nicely in this population for adults and kids, not just kids, would be helpful. Comorbid substance use. Again, with that dopamine, people, substances coming off substances, they don't want to be blocked. They don't want to be flat, very sensitive to that. Agitation and Alzheimer's. I know we have other agents that have been approved, but again, in terms of cardiometabolics, in terms of speed of onset, many people feel cariprazine superior. We have no FDA-approved pharmacologic treatments in borderline personality disorder. Again, there's a lot of mood lability involved. There can be micropsychotic episodes, agitation. Cariprazine could be helpful there. Then we have pediatric bipolar, but more important than that is DMDD.
Oh, yes.
Disrupted mood dysregulation disorder is a diagnosis that doesn't have an FDA-approved treatment yet.
That's right.
And people are not diagnosing bipolar well in kids, but they are diagnosing DMDD quite readily in kids. It's again another orphan that doesn't have a treatment. Bipolar 2, I think, is worth studying. I think all of us clinically probably use it for bipolar 2, even though that's not what it's indicated for. MDD with mixed features. This is an exploding field right now, because you have a lot of people who you may think, well, let's add a little bupropion to give them that lift. But you give them that lift, you make them irritable, make them agitated, make them anxious. Vraylar is uniquely suited for someone who needs a lift, but also needs the calming effects of that stabilization effect. Vraylar weekly. You have Prozac weekly. Once you've titrated up, few weeks to a nice level. Vraylar 1.5 or 3 in a weekly pill would be a very well accepted treatment for so many patients who are resistant to taking daily pills. Compliance issues, Vraylar weekly. And comorbid ADHD and bipolar. There's a lot of talk about this because it's kind of a quagmire. You have bipolar, which trumps the ADHD. So then you have to be on a lithium, you have to be on a Depakote, then you're going to add a stimulant, and the two are kind of fighting each other. Vraylar has potential in people who are mostly bipolar with some ADHD component because of that cognitive enhancement. A very nice piece. So when I've spoken to people about it, I guess heads up, you have cariprazine, you have D-cariprazine. So hopefully down the pike, we'll see Vraylar 2.0 and the D-cariprazine with all these indications.
My goodness.
And a nice long life, I think could be a real hit. And I hope people are listening, because even right now, a lot of people have comorbidities, whether it's bipolar depression and some of these other things going on where it's still on label, but there's a lot of room for this molecule to grow and reach even more people. Well,
hang on here, because you've given me a lot to riff off of. First of all, cariprazine is my go-to drug for ADHD with mood disorders. I completely agree with you on that. Up to 30% of people with bipolar meet full criteria for ADHD. It's a very common comorbidity. I want to go back to a couple of other things. The borderline and the substance abuse. This is a drug that really, as we said earlier, stabilizes the motivation reward system. And these are disturbances of the motivation reward system, of impulsivity, which is a disruption of motivation reward, the ability to, prolong gratification, if you will, or anticipate gratification. So I think they are very creative ideas, but they are huge unmet clinical needs. And many of these things you brought up, as you said, you're 100% right. There's no FDA-approved treatment. But when patients come to our office, we can't say to them, well, I'm sorry, I can't treat you. There's nothing FDA-approved. We're going to treat them. And so a wise, experienced clinician like you has found this to be useful in those situations. And so I completely agree with every single one of the things you've said. Bipolar 2 is interesting. Only 2 drugs have actually got the approval, as we know, lumateperone and quetiapine. And that's largely because they're the only ones they included them in their pivotal trials. That doesn't mean the other drugs don't work for it. I think, as you've said, our experience is we use them for this. But it's good to have FDA approval for 2 main reasons. One is you can go to bat with insurance companies, and the other is we can educate and promote off of that. So, yeah, love what you're saying. I would be remiss. I can't go away if we don't bring Max back into the conversation. And you don't have to give us details, but you teased with me earlier. You've got to tell the audience just a little bit about what you guys are working on now, and that you actually have a poster you're submitting to NEI. So hopefully folks listening will come to the NEI Congress and certainly come and meet you and Max, shake your hands, and see your new poster. So what could they look forward to?
Okay, so just a little bit about Max. So Max has always been a science prodigy. Mm-hmm. So he expressed interest in being a doctor, going to medical school, learning science in high school. So I accompanied him to our local community college, and he did his whole pre-med curriculum during summers in high school.
Oh, you're kidding.
So he took high school bio, and then he took college bio.
Oh, my goodness.
And he took high school academy, and I saw him in an organic chemistry class because I was his lab partner. He was like Doogie Howser coming in from high school. And I said, don't worry, Max is coming. He would come in with his book bag, in his rollerboard, and he would come to the lab. And he was there in the organic chemistry lab, and he had the highest grade in the class by far. And I'm like, how are you doing this? Because the way I learned organic chemistry, I had to memorize all the flashcards. Yeah. He could actually reason out where was the leaving group, where was the attack group, where the molecules were. We did for his college a video for Brown, a little movie. And he wrote out the whole Wolff-Kishner reaction by memory. I mean, it was ridiculous. So he loved science. Yeah. So I said, you know what? Let's knock off the pre-med in high school. He took his MCAT at 18. He got in the 95th percentile, and he went to Columbia for undergrad. Got accepted at 19 for his medical school. And now he's in a 3-year med program at Hackensack. Yeah. And he probably will do an MPH just to kind of put some research chops on top of that. And he hopes to do an academic psychiatry residency. So he's building his portfolio, this research and this clinical experience, and also the posters. Yes. So coming up, we have a poster to present on a novel treatment for TRD, treatment-resistant depression. Right now, we have a nasal spray that has to be used in conjunction with an oral antidepressant. You have to come into the office. It's a 2-hour visit. It can be cumbersome for many people. And then we have the combination of Zyprexa and Prozac, Symbyax. But of course, you have the weight gain associated with that, cardiometabolics, libido. So this medication that we're going to be presenting on, that we did a similar study, doesn't have the cardiometabolic effects, doesn't have anhedonia, doesn't have libido effects. Works rapidly, 2 weeks, and very well tolerated. And it kind of goes against the conventional wisdom, as we're wont to do, as to why it should be superior to an active control that we pick. Okay. So that's all I'll say for now.
Just tease us.
But I think it'll be a very interesting, fascinating thing to look at. And I hope everybody comes over and says hello, and we get to meet you all.
Oh, that's great. Well, Richard, I've really enjoyed this conversation as always, and I look forward to seeing Max again. You are justifiably a proud papa. I completely understand. My son did me proud. I literally just got back from orientation at the University of Virginia, where my son is starting this fall. That was my medical school alma mater, so I feel your pride, your nachas. And I want to say thank you to the audience for listening. I hope you found this valuable and useful. And I do hope that if you want to hear other podcasts and you want to hear our other educational offerings, please go to our website, which is NEIglobal.com. And you can find our podcasts anywhere that you find podcasts, including Spotify, I've been told. And Richard, a lot of people listen to the podcasts, and so really appreciate you taking the time here to talk with us. Thank you so much.
My pleasure. Thanks for having us. Really appreciate the opportunity.
You bet. Take care.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.